Hey folks, Professor Finn back here, and we are going to be looking at Chapter 18, Preparation of Organ and Tissue Donors. So, generally, tissue and organ donation are not the same exact thing, hence they have different names. Tissues are collections of similar cells and the intracellular substances surrounding them. Tissue donation involves skin, eyes, ligaments, bones. Organs are any part of the body that exercise a specific function. Respiration, secretion, digestion, so kidneys, heart, liver, lungs are organs. Organ recovery and transplant is very time sensitive, happens to happen much quicker than tissues, and generally organs have to come from a living person. They keep them on life support until they can harvest. They can do tissue donation after a person is expired. The general numbers is tissue recovery must be completed within 24 hours of death when the body is refrigerated, and within 15 hours without. Tissue can also be preserved longer than an organ can. Organ transplant has to happen fairly quickly or the organ becomes unviable. All hospitals receiving Medicaid and Medicare funds must refer all imminent and actual deaths or risk losing their funding. In the Uniform Anatomical Gift Act, which we will talk about in funeral law, FSC 1080 here at Miami-Dade College, has been enacted by all states. It allows any person 18 years or older, essentially an adult, to donate all organs and tissues or the entire body for educational research or transplantation. Many states have taken the Uniform Anatomical Gift Act and created their own requirements. So be aware of what the restrictions are within your state. And the nice thing is that even under the federal law, which the state laws also exhibit, is that if you have acted in good faith, you cannot be found criminally or civilly liable for acting in good faith. Doesn't mean that you're not going to have to defend the lawsuit, just means that for the most part, if you've done everything right, they're just not going to win. So the organs that can be transplanted, there they are. You can even limit what it is that you want to donate. Embalming complications, well, come on. You know, they're taking parts of you out. You're going to have to kind of figure out what was taken, which you should know because there's going to be a gaping hole where something used to be, and kind of work from there. So review your embalming analysis or 10 as to how, what that means. And realistically, when you're doing an organ case, basically it's an autopsy. Just use all your autopsy protocols. Embalming is accomplished by raising vessels at one of the used injection and drainage sites. You can actually, make extra incisions if you want, or just look at where they were working and find something that works there, which I think would be the better practice for you personally. Realistically, you're probably going to be using 2 or more injection sites, an upper and a downer, because they're taking something. So we'll say for the sake of argument, they took your stomach. They might have interrupted your aorta right in your thorax. So then you're going to shoot north, you're going to shoot superior in that aorta to inject the upper extremities and head. You'll reverse it. You will inject south or posterior towards the feet to inject the lower extremities and feet, and away you go. You're done. In leakage, just like anything where you've been similar to an autopsy, is going to be something you have to worry about. You're going to have to be dealing with all those common problems that are associated with things like an autopsy. So transplant incisions, they give you 4 different ones. But essentially it's a big cut, okay? Big cut from probably the base of your neck all the way down south. It just is what it is. You might get lucky, base of neck to just above your belly button, or from the base of the sternum to the pubic bone, the T incision, or just a good old-fashioned midline, which is basically neck all the way down to the pubic area. Most embalmers can go ahead and work on this. We're already been trained for autopsy, so this is nothing new. This is actually easier because we're not having to put anything back in or treat viscera because the viscera have probably been taken. That's what's been transplanted. So you should have all the skills you need to handle this. Because of the delays, and we will talk about delayed embalming in the next chapter, you are going to have to use some stronger than average solutions. So probably something 2% or even higher. 2% is normal, so if we're going to kick it up a notch, probably between 3 to maybe 4% would be a little bit higher. Depending on what you see, 5 or 6%. Again, use your best judgment. You're also going to have to use all those supplemental treatments, cavity compresses, hypodermic injection that we do for autopsies, plastic garments, drying compounds and powders. All that sort of stuff is going to come into play. Take into consideration the nature of death as well as what they took. If a person died in a traumatic car accident, you have to deal with the facial trauma and all those sort of things, as well as what has happened to you when they went in and started taking things out. And you do have some really good charts in this book, okay? Some really good charts in this book. So look at those things that give you clues as to what might be asked on a test or what type of treatments are involved. With tissue donors, it's a little bit easier. Eyes are one of the most commonly transplanted or harvested tissues. Most common problems are swelling, some bruising, and some lacerations. If a technician really knows how to do their job well, you're really not going to encounter a lot of that. But realistically, what that means is you have to pay a little bit of attention to what you're doing when you embalm. Restricted cervical, no pre-injection because of the swelling, stronger than average index. What you put in needs to do the job of, two of itself or whatever. Don't go in there doing excessive manipulation and not trying to establish anything. The usual things. Apply massage cream around the eye, autopsy gel outside of eyelids. Do not pack the orbit too tightly because you want drainage to actually happen a little bit, but you don't want to encourage swelling. And just treat it like the body's going to swell. You should be okay. After injection, do what this says, dry everything out, go in, refill the orbit however necessary. And there's a little graphic on how to do that. You can probably run down to your favorite arts and crafts store and find stickers like this and post it on your notebooks to freak out all the other people you go to school with. Cornea removal, this is eye enucleation light, okay? Swelling is not as much. You might have to aspirate the fluid from the eye. For the most part, this isn't too much of a problem for us. The vertebral donor, taking the spine, you can imagine this is going to be problematic. As a rule, the technicians will attempt to recover as much as possible, but there may be limitations, okay? Procedure for removal and treatment is similar to that in the autopsy chapter, so a major concern is to ensure that they have not poked holes in places they should not have poked holes. If they have poked holes, that means the body's going to leak. So check the back thoroughly. Get someone to help you. Roll the body on its side and look for things that shouldn't be there. And definitely use plastic garments. Many tissue banks will even give you things, they almost always will, it's part of what they do, so that you don't have to go ahead and recreate something. So when they come, make sure they leave you the items that you need to repair things so that you are not creating work for yourself or creating at least expense for yourself. If the spine and other things have been removed, you're going to deal with the complications of that, as well as the trauma or whatever the situation was that caused the person to expire. Recovering the spine from the inside, known as the anterior, makes things a lot easier for us because the hole's on the inside. It's basically autopsy embalming 101. I find it amazing that people would take the spine but not take anything else, but yeah, you might have to work around the guts and whatever else, but chances are, hopefully, if you get a situation like this, it will be easier for you than having to work around intestines and everything else. So find what you can, utilize those arteries like the aorta, and make your life easy. The posterior incision is problematic because, yeah, it's on the outside of the body, but the plus is that it should interrupted anything vascular-wise. It's quite common that vertebral donation occurs with other types of donations, so it just kind of is what it is. Long bones are going to leak every single time. So you can see they make the incision and they go all the way to almost mid-foot. It is very much a leaky issue for us. And sometimes there's nothing left but skin that has been sewn shut. This is time-consuming, and it's also going to be time-consuming for you. So they're going to be there a while if they're doing it at the funeral home, and then you're going to be there a while fixing it when it's done. And this is kind of the no-brainer of it all. Solutions you possibly can based on your analysis. Whatever you're injecting needs to get wherever it can to do whatever it can there. They're going to be taking all these bones out, which means severe interruption of your vasculature. And the stuff that does pull needs to be able to basically contact embalm anything it comes into contact with. And then you're also going to be sitting there sniffing these fumes for most of the time you're in there. There is two methods. Method one, you can just kind of go through, you open the sutures, take out the supports, and then find the arteries and try to inject them, clamp things down so that as you go through, if you see something that's leaking, clamp it off so that it pushes fluid as deep into the leg as possible. Then go down, inject the foot as much as you can. And again, clamp off anything that's spraying fluid. And then after you're done, hypodermic injection. When you're done, it's preventative maintenance time, and it tells you what you need to do before you close things up. Make a note that you also want to maybe shoot into the buttocks and the pelvis area to make sure that those areas have been preserved as well. And then you suture everything tight, apply additional barriers, drying compound, plastic garments, you name it. Method 2, the free flow, you leave everything in place. Just kind of is what it is. You raise the iliac or femorals and insert the tubes to shoot the leg. Then you're basically shooting a waterless solution with very strong arterial, fast firming, all sorts of love. Equal parts fluid and water. A waterless solution is recommended. I'm sorry, going to say you probably want to go for waterless. Inject each leg with at least a ½ gallon of solution. Make sure it at least gets to the portions below the knee, and then stop and let things saturate while you inject the rest of the body. After a while, make a hole, drain things out. Prosthetic devices should be in place already. You don't have to really play with them. Cover the incisions and close things up like you would normally. Talks about a method 3, saturated packing. Essentially, you're opening things up, putting in an absorbent material, resuturing the leg, and then filling it with a undiluted cavity fluid or strong arterial. And then basically doing your good old time of a locking stitch every 5 like you were suturing up an autopsy. You're most certainly going to want to use plastic garments such as a capri on something like this. So the proximal humerus indicates only the humeral head and upper portion of the humerus are recovered. The scapula is also known as the shoulder blade. So basically now we're looking at an upper extremity. Okay. Basically, when a tech comes in to do any of this, it is their responsibility to get the body back to as close of a normal appearance as it can. That does not mean perfect color, etc. It just means things in place so that everything works. However, you might not want them to do that. You might want them to actually leave the stuff for you to put in after you're done your job. If you have never done this, you might want to watch how the stuff happens, have them teach you how to do it, and then take the stuff out and go so that you're not duplicating work every single time. But it is their responsibility to make sure those items are there for your use or restore the body before they leave. If this does leak, this proximal humerus sort of thing, usually not too bad because the incision is on the front portion of the shoulder, the anterior portion of the shoulder. So it's not really going to leak and go crazy. You should be able to control it relatively easily. If the scapula is recovered, okay, if they're going to take that shoulder blade with them, you're going to have problems because the incision is going to be in the back. Little disruption here to the blood vasculature, so most of the body should be okay. The only thing you probably have to worry about is the extremity, which you shouldn't have too much of an issue if you just go in there and find an artery that's standing around waiting for you to use it. Gives you the 2 methods. So I'm just going to kind of flip through these. You can kind of read through them. It's no big deal. Obviously, you're going to want to make sure you tie off everything properly to prevent as much leakage as possible. You're going to have enough fun taking care of things as it is. Don't make more work for yourself. Use supplemental treatments, packs, hypodermic injection, etc. Skin donors, you have 2 types, partial thickness and full thickness, or freehand. Okay. So for partial thickness, we use an item called a dermatome. Okay. Partial thickness uses a dermatome. For full thickness, the reason why it's called freehand is because we use a scalpel to actually cut down to the musculature. Full thickness removes the vascular layer of the skin, and generally less leakage will be seen because ain't nothing to leak from because it's all been taken out. You just have to dry things out and away you go. 3 problems. Discoloration because of the dehydration, okay? Drawing of the affected areas from which skin has been taken, and control of leakage from the borders. It says discolored facial tissues treated in the manner in which we've learned. Your book states that at this point, restricted cervical. Use of moderate strength fluid is recommended with the addition of dyes as tracers. For partial thickness, basically it's business as normal. They just took a little bit off the top, so to speak. So you're not going to have a lot of interruption. Embalm the body is normal. Turn the body on its side and use surface packs or gels or whatever you need. Cover with absorbent materials and seal. Plastic garments, definitely. If you've made any cuts and whole pieces of you are missing, you're going to want to do something to, make sure it doesn't leak all over that nice shiny new casket. Full thickness is very similar with less leaking because they've actually taken most of the pipes out, and all you have to worry about is the edges. So your book mentions bone and skin donors, but you just apply all the techniques you've learned. It's time consuming, so be patient. It's not difficult, it's just annoying. Mandible donors? Yeah, good time there, right? Typically, mandible donors are already non-viewable, which means you're probably not going to be dealing a lot with it. So it gives you the different methods. Basically, they're cutting open your face, ripping out your jaw. So you're probably not going to be in too good of a condition later, and all the complications that you can possibly imagine associated with cutting open someone's face and ripping out their jaw certainly are going to apply here. Ribs are recovered through vascular organ recovery, which are those 4 down the front of you, so to speak. After organ recovery, scalpel peels back the skin and every other rib is removed. Bombers generally just going to have to deal with disruptions of the intercostals. This is increased leakage. It's autopsy protocol. You're going to be using a Union anyways at this point, right? Temporal bones, going to rip out the bone on the side of your head. There's 2 techniques for it. You can basically rid this on your own, but for the most part, it's another leaky issue. You're just going to have to deal with it. Ear can be reattached with intradermal sutures or super glue. You probably want to make sure that people know not to be walking up and articulating the face and getting all, touchy-feely with it, because that can be a problem for you. Organ and tissue procurement is going to grow. It is inevitably going to grow. Knowing how to restore nation is going to become even more important. People want to help other people inherently, most of us. And this is one of the tremendous ways that people can do that. And you play a very vital role as a funeral professional in educating the public about this. Some people might not see the need for it and want to but don't think they can. You are ground zero to make sure that they have and make an informed decision. Best case scenario, you've informed them, they still turn it down, but at least they are okay with that decision. Worst case scenario, you should explain it, which is what someone, especially a jury, would expect if you walk in, speak to your funeral professional, just don't say, I don't know about it. No, it doesn't work that way. And you end up in a lawsuit, because had you been able to answer the question or at least refer them to the right 800 number, they may have chosen that. So you do not want to interfere, but be very helpful. You have every right to make sure that procurements that are done do not prohibit an open casket viewing. That being said, we just learned about the mandible, right? The fact of the matter is, if they take anything but something on the face or even the temporal bone, you should be able to fix that with just a little bit of your effort. So deal with each other respectfully and treat each other like professionals. It takes a lot of skill. What you do takes a lot of skill. Folks, thank you for your attention. We'll see you next time.